Welcome, everyone, and thank you for joining us today for our exciting presentation on the benefits of ultra-high frequency ultrasound for children with chronic diseases, first clinical experiences with the Vevo MD. Our presenter today is Dr. Frida Dangardt. My name is Dr. Christina Asa from VisualSonics, and I'll be moderating today's session. At this point in time, I'd like to introduce our speaker for today, Dr. Frida Dangardt. Dr. Dangardt is a cardiovascular specialist who obtained her MD in 2005 and completed her PhD in 2008. She has been working with ultra-high frequency, or UHF, ultrasound for over 10 years and published her first clinical article on assessing peripheral artery intimal thickness within the first 2 years of using the technology. Now, before I pass things over to Dr. Dangardt, I'd like to take this opportunity to introduce the topic of ultra-high frequency ultrasound for any of those who are unfamiliar with VisualSonics or our technology. In ultrasound, higher frequency allows you to obtain better resolution. In fact, with our UHF technology, you can get resolution down to 30 microns. Now, this increase in frequency and resolution is best depicted when you compare images taken from ultra-high frequency ultrasound with frequencies up to 50 megahertz, as seen on the left, with images taken from conventional ultrasound with frequencies up to 15 megahertz, as depicted on the right. Now, you can see on the left with UHF technology, you see detail that's never possible to be seen using conventional ultrasound. VisualSonics first designed this technology for preclinical imaging of tiny anatomy and structures in mice using our preclinical systems, the Vevo 770 seen on the top left, the Vevo 2100, and the Vevo 3100, our most recent preclinical system. Throughout Dr. Dangardt's presentation, she'll be showing you some clinical images obtained under special approvals using these preclinical systems. But what's extremely exciting is that she'll also be showing you some of the first images taken using our Vevo MD, now approved for clinical use. So without further ado, I'd like to pass things over to Dr. Dangardt for her presentation. Thank you.
So hopefully you can all see this now. So I'm going to talk about the benefits of ultra-high frequency ultrasound on children with chronic diseases and also share with you the first clinical experience with the new system of Vevo MD in humans. So today we're going to talk about the early detection of vascular changes in children and with obesity and other disease. We will also talk about determinants and progress of intimal and medial changes in pediatric kidney disease. I will also touch upon the value and importance of early detection and monitoring of cardiovascular disease in children with chronic disease, and also possible future implications for research and clinical use for the ultra-high frequency ultrasound. Now, for general background, I'm sure you all know that traditional vascular measurements have been used for many, many years, such as blood pressure, vascular calcification as shown by radiology, by X-ray, and also carotid intimal thickness by ultrasound. Now, the problem with the composite measure of carotid intimal thickness is that it is just that, composite measure. Although there have been some studies, even in children, showing that an increased carotid IMT is present in children with morbid obesity. They also have shown that there is an increased CIMT in children with type 1 diabetes, and with familial hypercholesteremia, there are more prominent changes in the vascular function than in the actual morphology of the vessels. There are also some indications that CIMT are increased in children with chronic kidney disease, or CKD, which has been shown by the group in London, where I've also worked. And I will come back to that later on. So using the carotid IMT, the limitations of the imaging are quite apparent when you look at these images. That is a composite measure of the intima and the media complex. And the studies on CIMT with ultrasound are ranging from 5 to 25 megahertz, where they call the 25 megahertz ultrasounds very high resolution. Now, even with the 25 megahertz probes, there is no possibility of differentiate between intimal and medial changes. So, with the high frequency ultrasound, we started in 2005, I think. We did the first scanning of a patient or a human. We had a system in our lab which we used for scanning mice coronary arteries. And we were also working on early cardiovascular changes in children. And we tried to determine how early on we could detect the changes and tried to find methods to use for that. So we thought, why not try to scan children using the high-frequency ultrasound. So we did, and by then it was called biomicroscopy because of the very, very high resolution. So we did the first validation study looking at humans ranging from children up to old people, and looking at different stages of disease as well, from healthy to those with known coronary artery disease. And we did also do studies with in vitro validation and validated the system against histology and found that there was a very, very good correlation between the ultra-high frequency ultrasound and histology regarding intima thickness and intima area. And as you can see, the intima in this sample is a bit thick, but it is very good. It does correlate very well with the ultrasound. And to further show, we did live imaging of scraping off the intima and then studying that also in the microscopy methods, which showed that we did scrape off the intima and nothing else very nicely. So looking at the different frequencies, this is just an example of ultrasound of radial artery in a human with 15 megahertz ultrasound, then 30 megahertz ultrasound, where you are almost able to see the intima, and then moving on to the 50 megahertz ultrasound, where you can actually distinguish between the IT, the intimal thickness, and the MT, which is the medial thickness. All right, so this is just to show you why we want to do this already in children. This is, of course, to stand a chance of changing the outcome, as you can do in a football match, hopefully. All right, so we did one study with healthy children where we wanted to examine sex differences, and this study was published in 2009, and it's called Sex Differences in Peripheral Artery Intima Media and Intima Media Thickness in Children and Adolescents. And why did we want to look at sex differences? It is, of course, because we already know from adult literature that males have a cardiovascular disadvantage. They have higher coronary heart disease lifetime risk, both in middle and in old age. and they also have an increased magnitude of atherosclerosis at other arterial sites than the coronaries compared to women. In both apparently healthy adults and patients with cardiovascular disease, the carotid IMT is thicker in men than in women. So with this background, we did the study on 190 healthy children, which showed that gender differences in vascular structures exist already in childhood, with an increased intimal thickness and intima media thickness in both radial and dorsal pedal arteries in males. And this may have implications for future vascular disease development. And this was already present in children 13 years old, which is interesting, of course. So we moved on to look at early vascular changes in children with obesity. And why did we want to do that? It's because the last 5 decades we've seen an alarming increase of childhood obesity worldwide. And these are just numbers up until 2010, where we can see in some areas that childhood overweight and obesity reach almost a third of the population of children. And we also know that there is an association between childhood body mass index and the risk of having coronary heart disease events, fatal or non-fatal, in adulthood. And these are numbers from a Danish study looking at almost 300,000 children, where a 1 unit increase in BMI Z-score is associated with an increase in having a CHD event in adulthood. So we did find that intima thickness was higher in children with obesity, but what we also found was that all of these changes was accounted for by the females. So males were equally bad off, so to speak, whether they were lean or obese regarding the intimal thickness, while females were better off if they were lean. And the females accounted for the whole difference between the obese and the lean group. And looking at some other measures we got from that study was the radial artery diameter, which was quite a bit larger in the obese children, with the same happening in the dorsal pedal artery, and this was coupled with a lower pulse wave velocity, which is a measure of arterial stiffness. So looking at these children again, 5 years later, they were 13 years old with the first study, and we examined them again at 15 years of age. We found that even though they had slightly lower pulse wave velocity at baseline, they had an increase that was much bigger than the lean children and had, at the 5-year follow-up, a much higher pulse wave velocity. This initially increased diameter that we saw in the peripheral arteries had further increased a bit, but at the 5-year follow-up, the lean children had almost the same diameter in their vessels with the growth. Intimal thickness changed similarly in both, as did the IMT, but as you can see at the follow-up, the obese children had slightly increased IMT compared to the lean ones. And looking at the blood pressures, the increase in blood pressure was similar between the two groups, but the obese children started at a higher blood pressure, both in systolic blood pressure. They started out lower in diastolic blood pressure, and the increase in diastolic blood pressure was greater than the lean children. So why is that? They had an initially low pulse wave velocity as a measure of arterial stiffness. They had no change in diameter, no significant change over the 5 years in diameter, but it was initially larger in the obese children. And they had quite a dramatic increase in diastolic blood pressure, which was initially low in the obese children. So this implies that the elasticity of the vessels actually decreased over the 5 years. And we would like to think of that as an initial coping mechanism with dilatation of the vessels as a response to the increased blood volume that the obese children have. But there is a limit to the capacity of dilatation, and that leads to a later arterial stiffening. So initially they have good compliance and they have dilatation of the vessels, and later on they get a stiffness. Right, so compared to the lean controls, the obese subjects presented rapidly increasing arterial stiffness, which was coupled with an increase in IMT and diastolic blood pressure over a 5-year period from early to late adolescence, indicating that this is an important transitional phase in which vascular changes occur. The increase in arterial stiffness and diastolic blood pressure after 5 years correlates closely to the baseline BMI set score, which is a corrected body mass index for children, indicating that childhood obesity has an adverse effect on vascular adaptation and that baseline BMI set score predicts pulse wave velocity. The widened peripheral arterial lumen and low pulse wave velocity observed in the obese at baseline 5 years earlier might reflect a structural adaptation to the increased blood volume and hyperkinetic circulation prevailing in the obese state. And the increase in arterial stiffness and diastolic blood pressure 5 years later suggests that childhood obesity has adverse impact on vascular dynamics occurring early in adolescence. And these findings also suggest that the early morphological findings we see are later on post-puberty, mainly dominated by functional changes, and again later on in life the morphological changes comes back and are more prominent with increased inflammation and so on. So what about the really sick children? We started with looking at children with chronic kidney disease, and why is that interesting? Yes, because we know that cardiovascular morbidity and mortality is associated with multiple risk factors for vascular changes. We have medial vascular damage with mineral dysregulation and uremic factors influencing the media. We also, in this disease, have intimal vascular damage with classical inflammatory risk factors for atherosclerosis. But these are less common in children, which makes them sort of a perfect study object for looking at medial changes. But these changes that we think would occur in chronic kidney disease may differ between different vascular beds. So we started looking at that. And in chronic kidney disease, unlike atherosclerotic calcification that is they have a very typical calcification in the media. And unlike normal atherosclerotic calcification that is typically seen in the intima, patients with CKD have medial calcification or arteriosclerosis that is known from adult studies and also from studies in children, as you can see here, where the group I was later on working in London has shown that there is a difference in calcium load in the vessel wall from histological samples. And calcification in the media involves vascular smooth muscle cell damage and calcification with deposition of crystals in a focal distribution, as can be seen at your bottom right. And this is especially prominent in dialysis. This is also interesting because cardiovascular disease is the leading cause of death in children on renal replacement therapy. This has been known for some time, and we of course wanted to see whether we can make some difference in this population. And this is to show that carotid IMT levels differs between controls and these patients as well, and this is associated to calcium and phosphate metabolism, which is impaired in the patient with chronic kidney disease. All right, so just a few examples of why this is was something we wanted to do. We have children that are ranging between 7 and 18 and matched controls. And as you can see in the children on haemodialysis, these are radial arteries. They have a very ugly looking intima with the increased intimal thickness and sort of scruffy looking intima. As in the controls, you can see a very straight, smooth intima and media. So looking at it in further detail, you can see here just a few examples of a healthy child on your left and a child on haemodialysis on your right. So we did the study in London at Great Ormond Street Hospital for Children. We did measurements of pulse wave velocity along with scans using the Ultra High Frequency Ultrasound, and that was the Vevo 2100. We had 54 children with CKD scanned. 19 of those was pre-dialysis, and at CKD with renal failure stages 4 to 5. We had 20 children on dialysis, and we had 15 children after renal transplantation. And we also did 1-year follow-up on 25 of these patients. So we also did standard ultrasound CIMT in 32 of these patients, and they had quite a normal CIMT in this group of children, actually 0.45 millimeters, which is within the normal range, I would say. There was a correlation between the CIMT measured by the standard ultrasound and the 40 megahertz probe, but it wasn't a perfect correlation, which we didn't expect either. So looking at the carotid artery, the intima was increased by 15% in the dialysis children as compared to the transplant patients. The medial thickness did not differ between these patients, and this is interesting because the intima is such a small part of the IMT complex, so this is probably why we wouldn't detect any differences between these groups just using the standard resolution ultrasound. So in the radial artery, we found an intimal thickness that was increased by 11% in the children with chronic kidney disease and 21% in those on dialysis. But there was no significant difference between the transplanted patients compared to healthy controls. And the medial thickness did not differ significantly between the groups, but as you can see on this slide, there is a big range of medial thickness in the dialysis group, suggesting that there might be children with increased medial thickness in that group as well. So looking at the dorsal pedal artery on the foot, we had a medial thickness increased by 30% in the children with CKD and 60% in the children on dialysis, but no significant difference in transplanted patients as compared to healthy controls, even though it looks like it might be slightly increased if we can increase the numbers. The intimal thickness, however, did not differ between the groups in this study at this arterial site. Okay, so looking at the follow-up results, we had children on dialysis, and those who had been on dialysis for more than 1 year had significantly greater carotid and dorsal medial thickness compared to those who had been on dialysis for less than 1 year. And in the CKD and dialysis children, higher carotid medial thickness at baseline was associated with increased serum phosphate and PTH levels, which indicated an impaired phosphate metabolism. In the transplanted patients, higher carotid and radial intimal thickness was associated with a higher total cholesterol, which is interesting and suggesting that there are different disease mechanisms coupled to intimal thickening and medial thickening. And at 1 year follow-up, the transplanted children had a decrease in carotid and radial medial thickness, but an increase in dorsal pedal intimal thickness. And those who did have that, an increased dorsal pedal intimal thickness, had an association with a higher systolic blood pressure set score as well. So in conclusion, in CKD children, strategies to target both metabolic and atherosclerotic risk factors should be initiated from an early age, and arterial changes may be reversible after termination of dialysis or kidney transplantation. So why are we talking about children, and what is really the value and importance of early detection and monitoring of cardiovascular disease in children with chronic kidney disease? Not only the children with chronic kidney disease have later cardiovascular changes and higher risk of cardiovascular disease, but we also know that children with type 1 diabetes, children with congenital heart disease and other types of inflammatory diseases, rheumatology related diseases and such, also have a very increased risk of cardiovascular disease as adults. So we want to see if we can start prevention for cardiovascular disease early on. And as our treatment for their main disease, their chronic disease, increases and improves, we also get children that has a longer life expectancy, and the longer they live, the more likely are they to actually die from something else than their original disease. And in most cases, that other thing is cardiovascular disease. So if we can find it early, we can prevent it. We can use these methods for treatment monitoring, we can use it for treatment optimization, and we can also use the results from studies as implications for new treatment strategies, such as early renal transplant, keep them on dialysis for less time, maybe insulin pumps for children on who has type 1 diabetes, and so on. So just to show you, this is the Vevo MD, and I'm going to talk about the clinical use for the Vevo MD in the pediatric department, but also maybe for the adult doctors. And I'm going to show you some images from a study we do in children after renal transplantation here in Gothenburg. So for you who have experience using the old systems, you will recognize the images on your right, which is called in the Vevo MD the raw mode. However, with image improvement, you have the HD mode in the Vevo MD as well, and those are the images on your left. So this is what I'm going to show you from now on. This is images from a 9-year-old healthy control female patient with the radial artery on top and the dorsal pedal artery at your bottom. What we did find as just sort of finding when we did the scan was a scarring of the radial artery. This is an 11-year-old boy who had renal transplantation 9 years prior to the scan, and we did an extensive scanning of all his vessels and found that this was the only thing we could see that was different from anywhere else. And as you can see, his intima and media thickness is quite normal, but he has this scar, which we think stems from a radial artery catheter that he got in the ICU when he had his transplantation. We will never know if that's the case, but this is the theory, at least. And if you look at his carotid artery scanned with the 15 megahertz probe, you can see it looks perfectly normal, and also the dorsal pedal artery, where you could maybe think that he has a slight increase in medial thickness, but nothing else. And this is just to show another of our patients. He's a 12-year-old boy, 10 years post-transplant. He is also obese, which means that we have other factors to take into consideration with this boy. The carotid artery looks fine. The measurements are normal. The radial artery is scanned with 50 megahertz. I'm sorry for that mistake. And the dorsal pedal artery looks perfectly normal, 50 megahertz ultrasound scanning. So he has normal blood pressure and no other risk factors other than his immunomodifying medication. Another chance finding we had was when scanning a control patient, a young female. We didn't know that she had any disease when scanning, but we found in the dorsal pedal artery very prominent medial calcification. And as you can see in this image, this is actually the first time anyone has shown in an ultrasound a proper medial calcification, because we can see the intima beneath towards the lumen. So we can see that the calcification is only present in the media and not in the intima. This is a live scan where you can see it properly. You can see the intima and the calcification making the normal echo shadows that you would see when you have a calcified other vessel. And on your right you have the millimeter scale, so this is a vessel that's about 1.5 millimeter in diameter, and this is the dorsal pedal artery in this patient. So now, when looking at this, we also did a scanning with the 15 megahertz probe, and looking at that is the image at the bottom of the page, where you can't distinguish. You would not really be able to see that it's calcium either. You wouldn't want to make that decision, I think. Might want to say, well, it's calcified, but you can never say that it's actually in the media. But using the 50 megahertz probe, you can properly see the intima below the calcification. And in these images, you can see a bit more calcification in the dorsal pedal artery. When scanning the radial artery in this patient, we found no calcification whatsoever, and neither any changes in the carotid artery. So another example is an adult with type 2 diabetes. And as you can see here, we have quite a prominent increase in intimal thickness, both in the radial artery and in the dorsal pedal artery, where you can actually see two white lines in the intima, which indicates that there is lipid deposition in the intima, as is expected in these patients. So this is what you can expect to see in adults with the beginning of coronary artery disease or type 2 diabetes affecting the vessels. And this is also what you see when you scan really old people, usually. Carotid artery images, 15 megahertz or 12.5 megahertz is what you will get with the standard carotid probe, and those look very, very nice, but you can't distinguish between the intima and the media unless you use higher frequencies of 40 and above. Another example, just to show what it could be useful for, is a thrombus in a brachial artery aneurysm that I scanned in a boy who had brachial repair surgery after a fracture in his elbow. And this is something we would never have seen unless we use the high-frequency ultrasound. And you can see a nice whirling of the echo and then the thrombus in the bottom of the aneurysm. So what could we use the ultrasound for in the future? We have in our ward started using the Vevo for venous catheter insertion in small babies where the arteries are difficult to find using even the smallest probe with the normal ultrasound. And what we can do there is also measuring the lumen properly and see if we can get which catheter would fit in the vessel, because in some of our examinations we need as big a catheter as possible, where we need to give a bolus dose of something to the children. So that's what we've started using as well. And in the future, we also want to do studies of children with cystic fibrosis, because this is an inflammatory disease which we think will affect the vessels. We know that these patients also have pancreatic insufficiency, which means that they will get diabetes with the cardiovascular risk that implies, and they also get pulmonary hypertension, which is another risk factor for vascular disease. Looking at children with congenital heart disease, we know that they get hypertension, they have increased rate of pulmonary hypertension, and also a big problem in these patients are inactivity, because often the parents are scared, the children are scared, and they've been told not to exercise, which means that they often get obese and inactive, and this is a risk factor in itself, and means that it would be nice to see if they have any vascular changes early on. And children with type 1 diabetes, they have, as we know, the glucose toxicity affecting the intima. They have microvascular disease quite early on, and kidney disease as well. So we could use this for treatment evaluation and optimization, and possibly implications for introducing new treatments for these patients as well.
Thank you very much, Frida. That was a really enjoyable presentation. One question that came in is more of a general question. We saw that you presented some data on intimal thickness as well as some data on intima media thickness, which is very commonly done. What are the main advantages of looking specifically at intimal thickness?
Well, the risk factors are different for intimal thickening as compared to medial thickening, or this is what we think and what we know from histological and animal studies. So looking at the intima, we will get changes stemming from, hypothetically, inflammatory factors such as CRP and other inflammation, and we will also have changes with the blood lipid levels and so on. As for the media, we know in chronic kidney disease that we have changes in the media stemming from the impaired bone metabolism, which will thicken the media with calcification and such. But in normal people, we think that the media will increase with hypertension. So the blood pressure will cause an increase in the muscle cells that are in the media, and this will be seen as a medial thickness increase. So it's
Great, thank you very much. Just another question here. You saw in your obesity, the study on obese children, that in adolescence 5 years later, you saw specific vascular changes. Can you hypothesize what you might see if those adolescents were then followed into adulthood? Would you expect any specific vascular changes to be seen?
Yeah, I mean, we know that there are studies on adults showing that they have a very impaired pulse-wave velocity, which means that they have arterial stiffening going on quite severely. And we do know that this is something that will affect them in terms of cardiovascular events. But what they will also have is, with the increased inflammatory response that they have, and as we know from biochemistry, they will also have an intimal thickening, I think. The problem with obese adults, though, is that with the scanning, with the depth, penetration depth of the 50 megahertz probe, it's difficult to reach even the peripheral arteries in these patients, actually. I've tried, so I know it's a bit of a problem.
Great, thank you, Frida. I think we have time for one final question.
Yeah.
Sure. Hi, Frida. This is Andrew Needles in Toronto.
Hi, Andrew.
Hi, how are you? Thanks again for today. I just wondered if you could maybe share with people on the line, your experience, given that you've done a lot of the work that you showed today with the preclinical systems where you've used them off-label under special approvals. Now that you've a truly clinically approved system, how has it made a difference in your typical daily work, your workflow, and have you seen a difference?
Yes.
And just maybe speak to those experiences.
Yeah, of course there's a difference, because now I can scan the patients that come to the ward rather than only those in the studies. So that's why we just now started using it as needle guidance help and so on. So, I mean, of course there's a difference, and I can use that ultrasound when I need to and not only when it's a study. So, and I mean, I think we can use it more and more as we find other things. And we've actually just now started scanning also children that have peripheral venous thrombus from venous catheters to follow them and see that they go away with treatment. So in the ICU where this is a problem. So, I mean, there are lots of clinical implications for this system as well, especially in small children.
Sure. Okay. Well, that's great to hear. I guess maybe just as a follow-on to that, I mean, what I was curious about is now that, for example, you're detecting this calcification, which you hadn't maybe expected to see or hadn't been able to see before, what would be, I mean, now that you can actually see it, what sort of clinical path might you take with that information?
I mean, this is, as I said, for treatment optimization. We can try different strategies for treatment, and that's also what we've done in some of the children where we've seen that they have an increased intimal thickness, and we know that they have slightly increased blood lipid levels. We can decide to actually put them on statins that we didn't really used to do, and hopefully as we follow them up, they have a slightly decreased intimal thickness later on.
Okay. All right.
So,
okay. No, that makes sense. Thanks very much.
Okay. I think,
thank you so much.
Yeah, thank you, Frida. And I think that's about all for our time today. So I want to thank everyone for joining us today and for your patience. And we do encourage you to continue and connect with us at Fujifilm VisualSonics through our website at www.vevomd.com or visualsonics.com. And you can submit questions and requests via web forms there. Please keep track of our webinars that are available on our website and register for our next webinar. You can find us on our social media channels. We attend conferences and congresses, so please visit us at the booths there. And if you do have any questions about our products or technology specifically, I have included some contact information here for Andrew Needles, as well as Ingrid Seinen in Europe. So thank you very much and have a great day.